Good evening, everyone. My name is Ayush, an intern at Sipher. Uh, I welcome you all today to celebrate the Sjögren's Day, World Sjögren's Day, uh, which is celebrated on July 23rd. Uh, I request you all to open your cameras for a screenshot.
Yes, you can take a screenshot if you want.
Thank you.
Yeah.
Good afternoon, everyone. I'm Ayush Mishra, an intern at Cypher, and it's my pleasure to welcome you all to our webinar celebrating World Sjögren's Day 2025. We are glad to see participants joining us from across location. Your presence reflects a shared commitment to raising awareness about Sjögren's syndrome, a serious yet often overlooked autoimmune condition. Today is not just a commemoration, but a chance to learn, share, and support those affected by this disease. I encourage you to use the chat box to ask questions and share your thoughts throughout the session. Without further delay, it's my honor to introduce our speakers. Dr. Rakesh Gupta from Sipher, Dr. Prashant Agarwal, Indian Rheumatology Association, Dr. Ashok Sharma, Professor PGIMER. Now let's begin. Thank you for joining us. Dr. Rakesh Gupta, President and Director of Strategic Institute for Public Health Education and Research, Sipher. I request him to take it forward.
So thank you, Ayush. Yeah, can you move the slides? Yeah. So understanding Sjögren's syndrome, it is a systemic autoimmune disease, and World Sjögren's Day is commemorated every year on July 23rd. It is a powerful reminder of the importance of the awareness, empathy, and advocacy. This day honors the legacy of Dr. Sjögren, the Swedish ophthalmologist who first identified the disease, and more importantly, it uplifts the voices of millions living with Sjögren syndrome, a chronic, systemic autoimmune disorders that affects the entire body, causing fatigue, joint pain, severe dryness, among other debilitating symptoms. Too often, those living with Sjögren's face years of delayed diagnosis, a delay of understanding, and limited public awareness. World Sjögren's Day is a call to change the narrative. It is an opportunity for families, friends, healthcare professionals, and broader community to come together, learn about the disease, and offer meaningful support to those affected by it. Next, please. So Sjögren syndrome is a systemic, as I told you, it is an autoimmune disease characterized by extensive dryness throughout the body, while dry eyes and dry mouth are the most common symptoms. Patients may also experience profound fatigue, chronic pain, major organ involvement, neuropathies, and lymphomas. The disease progress varies from person to person, with some experiencing mild discomfort, while others enduring debilitating symptoms. Early diagnosis and appropriate treatments are crucial to prevent serious complications and enhance patients' quality of life. Despite common misconceptions, Sjögren is not a rare disease. It is one of the most prevalent autoimmune disease. So next, please. So I'll invite Dr. Ashok Sharma, Director, Cornea Center. He's an ex-president of Chandigarh Ophthalmological Society, founder, honorary secretary, Eye Bank Society of Chandigarh, and he's ex-member of the executive committee, Eye Bank Association of India. So he'll be talking about the ophthalmic signs and symptoms in Sjogren's disease. Thank you. So Dr. Ashok
Good
Sharma, so
evening,
you can carry.
everybody. Yeah. Good evening, everybody. At the outset, I would like to thank Dr. Rakesh Gupta, President Sipher, for giving me opportunity to speak in Sjögren syndrome 2025. This is important to create awareness about the Sjögren disease and its various ramifications. And one of the ramification is dry eye, which is very important. So in next few minutes, I would like to cover dry eye syndrome and current management. Why it is important to talk about dry eye? Because dry eye is a very common problem. You will be amazed to know that nearly 40% of the general population may be affected. And when we see patients in cornea clinic, the incidence is more than 50%. And most of the patients who are undergoing cataract surgery, up to 90%, they may have dry eye. Either they may have dry eye before cataract surgery or they may develop dry eye after cataract surgery. So it becomes very important because it affects the quality of life, and sometimes if the dry eye is severe, it can cause complications which can be vision threatening. Before we go on to the dry eye, I would like to make our people aware about the ocular surface and the tear film, how it works and how it helps our eyes to maintain good eyesight. Tears, they have like three components. Outermost layer is a lipid layer, which is protective and it protects the tear evaporation. Then we have aqueous layer, and innermost layer is the mucin layer. So all these components are important to have the normal tear film. And this normal tear film is important because it's not only like protective, nourishing, it also prevents the desiccation of the epithelial surface. And in addition to the tears which are secreted by the lacrimal gland, we have important secretion from the meibomian glands, which is in the form of lipids, and that is also equally important. So any disturbance in the above tear film components causes dry eye. Dry eye, if we want to understand, is a multifactorial disease. And when the dry eye occurs, the tear secretion goes down. There is increased osmolarity of the tear film, which induces ocular surface inflammation. And the other component is meibomian gland dysfunction. We just discussed that meibomian gland provides the lipid layer. So once there is a dysfunction of the meibomian gland, then this lipid layer is not there, and tears, they get evaporated. So we get evaporative kind of dry eye. So dry eye, if we understand, is a multifactorial disease, and various components which are important in dry eye is tear film instability, hyperosmolarity, apoptosis, and inflammation. Basically, ocular surface inflammation is the key factor, and it keeps the dry eye as a vicious cycle. So once there is a inflammation, this causes further decrease in the tear film secretion, and it increases the severity of the dry eye. So in long-term management of the dry eye, it is important to cut down the inflammation. And we have various modalities, treatment modalities for that, which will be coming later. In inflammation, we have a lot of ocular surface inflammatory mediators which are secreted, and these mediators, they do cause damage to the corneal epithelial surface. And if this is allowed to persist, then it may cause epithelial breakdown in the form of SPK, which we can observe clinically. So it's important to cut down inflammation to protect the ocular surface in the long term. When we consider the dry eye, we always have two types of dry eye. One is aqueous deficient dry eye, and the other form is evaporative dry eye. You will be surprised to know that in recent years, the evaporative dry eye incidence has gone up. And it has been shown in various studies that evaporative dry eye is alone or in combination with the aqueous deficiency dry eye is much more common. And it may be to the tune of 4 times the aqueous deficiency dry eye. These are some of the well-known causes of the aqueous deficient dry eye. These can be immune mediated, especially the most important one is the Sjögren syndrome, which we are making people aware of. And then we can have conjunctival cicatrization, because of which the tear secretion goes down. Neurogenic problem, when the neural arc is affected and there is decrease in the tear secretion. Of course, in addition to that, menopause and systemic medications. Lacrimal gland loss, which can be various reasons for that, like it can be congenitally absent. Then some of the syndromes like hydrotic ectodermal dysplasia, it can be iatrogenic, it can be traumatic also. So, meibomian gland, in addition to aqueous deficiency, there are various disorders which can cause meibomian gland dysfunctions, and these can be divided into various groups. Meibomian gland dysfunction, which can be primarily in some of these diseases, ocular surface related. Then systemic disorders, they can also be associated with MGD. And some of these are like psoriasis, ichthyosis, atopic dermatitis, seborrheic dermatitis, rosacea, and other disorders like lid disorders, Parkinson disease, contact lens wear, they can also cause meibomian gland dysfunction. Now, when it comes to practically management of the dry eye, one is we always try to distinguish between the aqueous and evaporative dry eye. And then in addition to that, we always try to look for the underlying cause of the dry eye, especially if the dry eye is moderate or too severe and the patient is in middle-aged group. We always try to rule out the collagen vascular disorders, for which we order some of the tests, and in more details this area will be dealt by my colleague. And dry eye with secretial disorders like Stevens-Johnson syndrome and ocular secretial pemphigoid, they are also important because these cases are also having ocular surface inflammation, because of which we can have the perpetuation of the dry eye. These pictures, they show like the degree of the ocular surface damage. You can see in green dots, which are less, that is the mild SPK. And then you can see much more staining of the fluorescein, where we have severe SPK, patient is too symptomatic in these cases. These are some of the characteristics of the evaporative dry eye, because you can see in the meibomian glands in the lids, they are not functioning. So that can cause the lid margin vascularization or squamous metaplasia of the gland orifice. And then we can have a decrease in the lipid volume and increase in the evaporation, causing the evaporative dry eye. And this is another group of disorders which we discussed, ocular secretial pemphigoid, in which there is shortening of the fornixes and gradually the worsening of the dry eye. And this usually occurs in the old age, but in young patients also this syndrome has been reported. A diagnosis of the dry eye largely remains clinical, but we have a battery of tests which can be performed. The most important test in the clinics we perform is the Sharma test, and also we can go for the tear film breakup time. Although there are many tools available in the form of automatic machines, we can have these values of tear film breakup time and meibomian gland status. But largely, the clinical examination remains the most important. And of that, slit lamp biomicroscopy is important. We can always look for the tear film height, tear film debris, and then mucus strands. These are some of the slit lamp photographs which shows that there is epithelial damage. We can looking for the tear film height, and the tear film debris is also visible in the angle between the cornea and the eyelid margin. These are some of the stains which can be used to determine the ocular surface damage. These are fluorescein, rose bengal, lissamine green. Of these, rose bengal is little painful, so we need to use only when we require it. Otherwise, fluorescein is most commonly used. These are some of the machines which can be used to do the mammography test, which can automatically give us the non-invasive tear film breakup time. And in addition to that, it can do mammography, and we can have pictures of the meibomian glands. We can quantify how many meibomian glands are not functioning. So we can also diagnose the dry eye. We can also know the effect of the treatment doing these tests. Now, coming to management, the whatever is the cause of the dry eye, the treatment always remains the artificial teardrops. That is the mainstay of the treatment. Now we have various types of artificial teardrops, and it goes with without saying that whenever we are treating dry eye, moderate to severe, we always go for the preservative-free artificial teardrops, or we can go for the safer preservatives. And these are some of the molecules which have been used in dry eye for different categories, like artificial teardrops with HPG is especially important for evaporative kind of dry eye. And then artificial teardrops containing lipid triglycerides, phospholipids, castor oil, they are also very good for the evaporative dry eye. Osmoprotectants, L-carnitine, erythritol betaine, protect the ocular surface epithelial damage. So all these molecules, they can be used depending upon the requirement. Uh, these are some of the modalities in addition to artificial teardrops which we use. These are in the form of like puncture plugs, anti-inflammatory in the form of cyclosporine, and then sometimes when the patient is having very severe dry mouth, we always use even oral pilocarpine. Autologous serum drops are very useful when we have epithelial breakdown, bandage contact lens, scleral contact lenses. All these modalities are useful in various degrees of severe dry eye. Systemic immune suppressive treatments are important when the underlying autoimmune disorder is the underlying cause for the dry eye. In addition to that, some of the surgical procedures like amniotic membrane transplant, lid surgery, or tarsography, oral mucous membrane graft, they are also being used in severe cases when we have lid margin keratinization and ocular surface damage with non-healing epithelial defects. Some of these modalities like topical cyclosporine we use twice a day. There are various formulations of cyclosporine. We use it twice a day, and it cuts down the ocular surface inflammation. Sometimes this cyclosporine is not tolerated by the patient because of irritation. Then we always start like topical steroids in addition to cyclosporine, so that the cyclosporine is tolerated well. Oral doxycycline is important. It improves the quality of the tear secretion, especially in MGD, and it improves the meibomian gland dysfunction. And these are some of the other treatments for MGD, like warm compresses, improved eyelid hygiene. Of course, we discussed doxycycline. Another option is using topical cyclosporine and omega-3 fatty acids. Coming to some of the clinical cases, now these two patients, they were having Sjögren syndrome, very severe, and they were having SPKs in both eyes, not able to open the eyes. So we gave them multiple treatments in the form of artificial teardrops, like omega-3 fatty acid, topical cyclosporine, and the patient improved, and they were able to carry on their routine activities. We have also studied the effect of cyclosporine plus autologous serum, and we have found that the anti-inflammatory effect is much more if you use it along with the autologous serum. And this publication has been published in a very prestigious journal of cornea and ocular surface, and that is Current Eye Research. This is a landmark article and published by Dr. Rajan Sharma. Punctal plug insertion is important. This helps us to retain the artificial teardrops for longer period. Contact time is increased, and some people are extremely happy with this. These can be either temporary or permanent, but we always go for permanent if we want to use this modality. Little bit about computer vision syndrome. We know that when we are working on these gadgets and we have increased screen time, our blink rate goes down and we have relative dryness. So good way to avoid this phenomena is that you use 20-20 rule, in which after every 20 minutes we have to look at a distant object of 20 feet away for 20 seconds. And one should do frequent blinking. And if patient is having a dry eye, then he should also use artificial teardrops. Frequent breaks in between the screen time uses is important. In addition to that, proper diet and proper exercise or yoga will also help. Dry eye also affects the satisfaction of patients who undergo LASIK. And we know that in case the patient is having a dry eye before LASIK or after LASIK, patient always has low satisfaction after the surgery, although the correction may be very good. So we need to take care of these patients by treating dry eye either before surgery or making them aware that you will have to undergo dry eye treatment for a longer period to have good results. We can also select a procedure where there is a least chance of developing dry eye, depending upon the severity of the dry eye. And in pre-existing dry eye, it is always better to treat dry eye, find out the cause, and then do the LASIK. In LASIK, basically because we are cutting the nerves, corneal nerves, so neurotrophic keratopathy is another issue which is important. Then, when we are examining these patients, multiple white dots on topographic maps, they may also indicate that the patient is having a dry eye. And increased higher order abrasions are also indication for the dry eye. A role of vitamin D in dry eye has been evaluated, and it has been found that if you give vitamin D, patients' immunity is improved, and vitamin D supplementation also improves tear film breakup time, tear secretion after 2 to 6 weeks of treatment. Cataract surgery in dry eye is challenging, and we have a publication where we demonstrated that if you do not treat the dry eye adequately, you are bound to have complications and sometimes vision-threatening complications also. Now, some of these cases, like this patient came to us with very severe dry eye in both eyes. We treated her dry eye, and she was mobile, and then she got cataract. And after treating a dry eye, we did cataract surgery also, and with good visual outcome. And but only thing is that the patient should have good follow-up. They should go on coming to us, and then we change the modalities depending upon the requirement. This is another patient who had corneal perforation because of the dry eye. So we treated the perforation, and after treating perforation, she developed cataract. So we did cataract surgery with good outcome. So you have to treat dry eye or dry eye sequelae before taking these patients for dry eye. This is very important slide because the images below show that this patient came to me. Somebody did cataract surgery in right eye without realizing that the patient is having severe dry eye. And after cataract surgery, this patient got endophthalmitis and also corneal infection, very severe. So we could not save the eye, and after controlling the inflammation and infection, the patient developed cystitis bulbi, as we are seeing. The other eye also, patient was having severe dry eye. So we treated severe dry eye for 6 months, and after 6 months, we did cataract surgery with good visual outcome. So important thing is that you detect the dry eye, treat the dry eye for longer period, and once ocular surface is stable, then only you do the cataract surgery. Above that, there are two slides. Again, this patient was one-eyed patient and were very anxious to get cataract surgery done immediately. But we treated this patient for dry eye for long periods. We also put the puncture plug. You can see the puncture plug is visible there, white dot. And after that, we did cataract surgery, and patient is enjoying good vision. And this thing we did around 20 years back, and now the patient is 97 years old and still enjoying good vision. So this is the importance of diagnosing and treating the dry eye before doing cataract surgery. Well, I would just mention that it's just like Israel converted their deserts into green, you can say, forest by taking care of the dryness. So we can also convert the our severe dry eye patients into seeing patients with comfortable symptoms if we treat the dry eye adequately. We know that dry eye treatment is very essential, and somebody said that eyes are powerful, eyes are delicate, eyes are beautiful, and keep your eyes on stars and keep your feet on the ground. I would like to conclude by saying that dry eye is an underdiagnosed condition. Many a times patients come to us with the symptoms, and when we diagnose them, we see them, they have dry eye for their symptoms. And sometimes patient comes for even for that I'm not able to see near at presbyopia case, but we find that they are having dry eye only, and if we treat dry eye, their symptoms are gone. Evaporative dry eye is on the rise, as we discussed. Always have to rule out systemic autoimmune disease, because if we do not rule out systemic autoimmune disease, the dry eye will go on worsening, and concomitant treatment of autoimmune disease is very essential in essential part of the dry eye management. Post-COVID, computer vision syndrome has increased, and patients sometimes they have so severe symptoms that they are not able to open their eyes, they are not able to do their work. So we have to use various modalities to treat these patients and make them comfortable. Some of these patients we have to treat even with autologous serum. Treat dry eye before LASIK or cataract surgery for optimum visual outcome, so that patient is satisfied and is asymptomatic. Well, thank you very much for patient hearing. Any questions I would like to address, whether on email or uh, we
Yeah.
can do it.
So thank you, Dr. Shok, for your wonderful presentation. So it will be useless for general physicians, eye surgeons, I'm general ophthalmologist, and even public health specialists will also benefit from your presentation. So you told us about the current management of the dry eyes, and you said that 40% they are actually affected. So dry eye disease is almost in 40% of the cases, and in corneal clinic definitely it will be more. And you told about the tear film constituents, the dry eye, and the MGT dysfunction. And you also told about two types of the dry eyes: aqueous deficient evaporation dry eyes. So I think Sjögren disease is an important cause of the dry eyes. So it is important for commemorating this disease. Yeah, thank you.
Okay.
So Dr. Prashant Agarwal is a consultant immunologist, rheumatologist and immunologist, and he's from the Punjab Immunology Center from Ludhiana. And he'll be talking about Sjögren's What You Need to Know. So thanks a lot to Dr. Prashant for joining us.
So first of all, I would like to thank Dr. Rakesh Gupta for giving me this opportunity of sharing my views on an important disease on a very important day, the World Sjögren Syndrome Day. I'll be sharing my views on Sjögren syndromes in 2025. I don't have any disclaimers pertaining to this talk. First of all, the definition. When we are about to talk about the definition of Sjögren syndrome, the terminology of Sjögren syndrome is also undergoing a change. Earlier, what we used to call Sjögren syndrome, it is proposed that it is now called as Sjögren disease. And why that change is being done is that they are trying to imply that even one single manifestation of Sjögren, that is a disease in itself, and you need not wait for the entire manifestation of Sjögren's to come. So this is a new terminology which has not been entirely accepted, but it is expected to come up in a big way. That Sjögren syndrome will now be referred to as a Sjögren's disease. What exactly is Sjögren? Sjögren is a systemic autoimmune disorder. Both the words systemic and autoimmune are important. By systemic, we mean that it is not only going to affect the eyes, it is not only going to affect the salivary glands, but it is going to affect the entire body. The characteristic features of Sjögren's are hypofunction of the salivary glands and the lacrimal glands, manifesting as dryness of eyes and dryness of mouth, but it can affect other organ systems of the body. It can have generalized systemic manifestations as well. So what do we mean by systemic autoimmune disorders? By systemic, we mean it can affect various organs of the body. And by autoimmune disorders, in case we try to tell it in Hindi to our patients, then the definition comes as Swapratirakshi Rog. So that is more complex than the word autoimmune disorders. The educated people who can speak English tend to understand what autoimmune disorder is, but majority of people are not comfortable with the language English. So in case you have to explain to them what an autoimmune disorder is, that is really a task. And that is why actually in India we face a challenge in making our patients aware of what exactly Sjögren is and what exactly autoimmune disorders are. Just like in case you look at some of the other common disorders, just like diabetes, patient very understands इसको शुगर की प्रॉब्लम है, hypertension they know कि इसको बीपी की प्रॉब्लम है. But for Sjogren, we do not have an exact Hindi word that we can tell to our patients. We don't even have an exact Hindi word to tell to our patients what an autoimmune disorder is, and that actually is a very big problem for us. In case we use those terminologies which are specific to our population, which patients can understand, which patients can understand the native language or at least in Hindi language, that will go a long way in making our patients aware regarding these disorders. So Sjogren's earlier was known as primary, when Sjogren's was acting independently without any other autoimmune systemic disease, and secondary when it was secondary to other autoimmune systemic disorders, and overlap when there was Sjogren's syndrome plus features of other systemic autoimmune disorders. Again, this terminology is going to change. Now, instead of using the word primary and secondary, it is going to be Sjogren disease or Sjogren disease associated with other disorders. Therefore, Sjogren syndrome very important disorder. Is the
नेट
gene
वाला
causes.
नेट वालों की जान हो पैसे किस चीज के दे देंगे.
These are some of the important milestones in our understanding of Sjogren syndrome. The first case was dryness of eyes and insufficient tear secretion was reported way back in 1880. Then, along with that, the swelling of salivary and lacrimal glands was described by an ophthalmologist by the name of Mikulicz, and that is why the Sjogren syndrome in earlier forms was known as Mikulicz disease. After that, the term Sika syndrome was coined, when it was found that not only the eyes, when the oral cavity is undergoing dryness, it can lead on to dryness of the vagina. Subsequently, it was discovered that these symptoms can be associated with systemic disorders like arthritis. In 1993, Sjogren syndrome was coined. It was also suggested that Mikulicz disease is a subtype of Sjogren syndrome. In 1958, autoantibodies were discovered. Then subsequently, gradient system for the labial gland biopsy was listed. The current criteria that we are using for Sjogren syndrome was laid down in 2016. It was a joint venture between American College of Rheumatology and European League Against Rheumatism. So, a broad overview of Sjogren's, it is characterized by glandular function impairment, predominantly in the eyes and the oral cavity, but it can affect other organ systems also. It can lead on to vaginal dryness, skin dryness as well. And the disease is not limited to glands. It can affect various other organ systems of the body. It is also associated with evidence of immune abnormalities in the form of autoantibodies in the serum, immune infiltrates in the biopsy, and association with other immune symptoms. To call patients suffering from Sjogren syndrome, we need to rule out alternative causes. It is not an uncommon disorder. It is found in up to 60 people per 1 lakh population. It is more common in females. Average age of onset is 45 to 55 years, but it can take place early on also, it can take place in children also, and has a worldwide distribution. Exact etiology of this is not known, but it is a multifactorial disease, and it is believed to be a combination of genetic plus environmental factors, leading to an abnormal immune response. The key characteristic in this is that the glandular health undergoes an impairment, thereby leading on to impaired secretion from the acinar cells. In addition to that, the ductal cells, the hygiene of that area also tends to go down, and we can find immune response taking place over there, leading on to infiltration by autoreactive immune cells. At a cellular level, the follicular helper T cells, they lead on to activation of the B cells, which then secrete a lot of autoantibodies, and that leads on to perpetration of the immune response and tissue damage. The key pathological finding that is found on minor salivary gland biopsy is focal lymphocytic sialadenitis in the exocrine glands. The infiltrates that are found are predominantly T cells, but B lymphocytes, plasma cells can also find. The typical biopsy finding is we get more than 50 lymphocytes. So the typical biopsy finding in a patient of Sjogren is aggregates of more than 50 lymphocytes. Now coming on to the symptoms, what are going to be the symptoms? Symptoms can be broadly categorized into the glandular symptoms of Sjogren's. Some of these features are very well highlighted by Dr. Ashok Sharma. Apart from that, it can lead on to systemic features pertaining to the other organ systems that can get affected, and constitutional symptoms, because of a systemic inflammatory response. So the glandular features are xerophthalmia, which has been discussed already. It can lead on to dryness of eyes, gritty sensation in the eyes, sticky eyes, and thick secretions, especially in the morning. जिसको पंजाबी में लोग कहते हैं जी सवेरे बहुत गिड्ड आंदी है आंख दे विच. It can lead on to xerostomia, dryness of mouth, difficulty in chewing dry food, and lot of caries. Caries can take place at atypical sites also, like incisor teeth can also develop caries. It can lead on to skin dryness. It can lead on to vaginal dryness as well. Examination of the eyes has been discussed already. I will not go into that. On examination of the mouth, you will find that the mucosal surface is going to be dry at past. The tongue is going to be dry. Tongue is going to be smooth. There is going to be decreased or absent papillae. There can be caries, sometimes at atypical location, and you can find enlarged parotid and submandibular glands. This was one of my patients. You can notice that the patient has got caries affecting the incisor teeth also. She has got caries of the molar teeth, which can be very common, but which can be commonly found in general public. But caries of the incisor teeth should make you feel alert. You can also notice that some of the papillae of the tongue, they have become smoothened out. This is where the parotid gland lies. In Sjögren syndrome patients, especially in acute inflammatory phase, you can find fullness in this area, you can find tenderness of this area and swelling of this area. Then there can be constitutional generalized features like fatigue, low-grade fever. Fever typically in a Sjögren syndrome patient does not cross 100 degree. In case it is going more than 100 degree, that would either mean the disease is entering into a more systemic phase, a vasculitic phase, or there could be some superadded infection. Patients can have sleep disturbance and generalized body aches. Apart from that, there can be systemic features. It can lead on to skin rash, it can lead on to arthritis, it can affect kidneys, it can lead on to Raynaud's, it can lead on to muscle weakness, muscle pains, it can affect the CNS. Peripheral nervous system involvement can take place and can be debilitating. It can lead on to mononeuritis multiplex. It can cause cytopenias, thrombocytopenia. It can lead on to lymphadenopathy. Lymphoma is not a very common complication but can take place and can affect the lungs. So almost any organ of the body can get affected. It can also lead on to secondary malignancies. This picture shows the typical palpable purpura of the lower limbs in a patient of Sjögren syndrome. This is because of vasculitis of the cutaneous vessels. So in case you find a young person who is having leukocytoplastic vasculitis, without any alternative explanation, do look for Sjögren syndrome in these patients. So this cartoon shows the various manifestations. The important point to note is that Sjögren syndrome can affect any organ system of the body. And these are the most common symptoms: dry eyes and dry mouth. Apart from that, can be swollen glands, skin rash, joint pains, muscle pain, and other organ system involvements. In evaluation, we need to take a very good history and physical examination. That is going to give you the majority of information. In eye examination, you can look for evidence of dryness of eyes. In oral, look for the salivary flow rate or nucleoscintigraphy of the salivary glandular function. Autoantibodies are very important. Patients can be positive for anti-nuclear antibodies, anti-rheumatoid factor. The key antibodies that we look for are anti-SSA antibodies and anti-SSB antibodies. We also measure the complement levels. In case C3, C4 level are low, that would mean patient is more prone to develop systemic complications. Apart from that, we measure the blood counts. We look at the renal and the liver function test, and always order for a urine routine test to look for any active sediment, which might indicate glomerulonephritis or renal involvement in patient or tubulointerstitial involvement. Also, always look for potassium levels in these patients. Sjögren syndrome can lead on to renal tubular acidosis, leading on to hypokalemia, and patients can have periodic paralysis. There are certain exclusions that you need to consider before labeling the patient as Sjögren's. Sarcoidosis is an important differential. Infection, especially HIV infection and hepatitis C infection. Patient can be dehydrated, leading on to dryness. Certain medications are very important cause: antidepressants, anticholinergics, and antihistamines. Mouth breathing, lymphoma, and advanced stage, all of these can lead on to manifestations which can mimic Sjögren syndrome. I would like to stress upon the drugs which are associated with dryness. In antidepressants, amitriptyline is a very important cause. Antihistamines are another important cause. Drugs used for incontinence and antipsychotic drugs. All of these can lead on to dryness of eyes. Then there are certain associations. By association means that patients of Sjögren disease are more common to have certain other associations like autoimmune thyroiditis and primary biliary cirrhosis. Prognosis of these patients, Sjögren syndrome is a largely benign disease. It is going to cause a lot of but will not lead on to decreased life expectancy. It is slowly progressive, but it can lead on to increased mortality, especially in patients who have got systemic manifestations like vasculitis, interstitial lung disease, lymphoma. Patients who have got low complements, cryoglobulins, lymphopenia, autoantibody positive, old age or male sex. They are also at a higher risk of developing higher mortality. What about management? The management of Sjögren disease is multidisciplinary, depends upon the extent of involvement, the organ systems getting affected, and what is the severity of involvement. These are some of the EULAR recommendations for management of Sjögren disease. In case patient has got only oral or ocular symptoms, ocular management can be largely topical management. You need not go into the immunosuppressive therapy for majority of these patients. Although in case patient is having severe dry eyes and severe oral symptoms, you can use muscarinic agonists like pilocarpine, which is available in India. You can also use saliva supplementation. For fatigue and pain, always evaluate these patients for fibromyalgia, and in case fibromyalgia symptoms are present, treat as fibromyalgia. And for systemic disease manifestation, you can use immunomodulatory treatments. A lot of immunomodulatory treatments have been used, like methotrexate, which has been found to be effective in patients with arthritis. It has got some modest effect on dryness of eyes and dryness of mouth, although statistically significant difference has not been found. Other drugs like leflunomide has shown some promising results in recent time. Rituximab again leads on to subjective improvement in these patients, but objective improvement at times might be found, at times may not be found. And patients, in case they've got organ-specific organ-threatening disease, then accordingly treatment can be used. Interstitial lung disease is an important consideration. In case patient of Sjögren is diagnosed as interstitial lung disease, evaluate what is the functional capacity, what is the extent of involvement, what is the impairment of the pulmonary function test. If it is just minimal, you just need to seriously observe the patient. Need not go into very high immunosuppressive therapy. But in case patient is symptomatic or is having moderate involvement, then corticosteroids along with a steroid sparing agent, mycophenolate or azathioprine, has to be used. Periodically monitor the response. If response is satisfactory, taper off the steroids, continue with the immunosuppressive agent. If still patient is refractory or progressive, you can use rituximab or cyclophosphamide. In case the disease is still progressive, fibrotic involvement is there, then antifibrotic treatment can also be used. Alternative agents are calcineurin inhibitors like tacrolimus. So to conclude, Sjögren disease is not uncommon, but it is often undiagnosed, and we need better awareness for our patients as well as amongst physicians. It is a heterogeneous disease. Glandular manifestations are the most common, but systemic involvement can take place. We need a detailed and careful assessment of our patients. For management, a multidisciplinary care is required, and treatment needs to be individualized for all the patients. Thank you so much for your patient listening.
Thank you, Dr. Prashant, for a very informative and a nice presentation. So you defined the Sjögren's disease as there is hypofunction of the salivary and the lacrimal glands, and it is a systemic autoimmune disorders, and it is like primary, secondary, and overlapping with other autoimmune diseases. It is there, and uh, and it is not that uncommon because 60 out of 1 lakh population, they are suffering from the Sjögren's disease. So thanks a lot. And the last slide, the concluding slide, was very important for all the doctors who are watching us. So can you just share your email ID with me on WhatsApp so that
I'll do,
if there are any questions, they can be just passed on to you.
sure, I'll do
Over
that.
to you, Ayush. Ayush.
Thank you all for being here with us today as we commemorated World Sjogren's Day. To our distinguished speakers and honored guests, your insights were not only enlightening but deeply moving. You helped us understand the very real challenges faced by those living with Sjögren's syndrome and reminded us why awareness, early diagnosis, and support are so vital. And to everyone who took the time to join us, your presence reflects your compassion and commitment to making a difference. We hope today's discussion gave you more informed, more connected, and more inspired to advocate for those affected by this complex disease. Let's carry today's message forward. Let's continue the conversation, support the research, and stand together in creating a world where Sjogren's is recognized, understood, and met with empathy. Thank you once again.